Thank you very much for the invitation. These are my disclosures. So let's start with the algorithm we adapted in Hamburg with distal first to proximal, staying with native, and Ellipsis actually fills that gap very good with regards to the results we see, and also with regards feeling between the radiocephalic and surgical Gratz fistula we are really fond of. And the Gratz fistula is actually the surgery behind the ellipsis. Well, the original one, or a modification by Klaus Conner, was anastomosing the perforating vein with a brachial artery, and then William Jennings modified it to anastomose it between the proximal radial or even ulnar artery to reduce the steal and high flow risk. And this is how Ellipsis actually works. This is a 6 French 1 catheter system. It works ultrasound guided. The access through the cubital veins. It immediately creates the anastomosis, fuses it by using thermal energy at the proximal radial artery between the perforating vein. And essentially the planning is the most important thing also for every access, but in this case you have to really look careful on the perforating vein, how the size is, how the length is, and especially how it lies with proximity to the proximal radial artery. And this is how the procedure works live. This is the intraoperative ultrasound. You can see the cubital veins connecting with each other, and then the perforating vein going down straight to the radial artery. This is the proximal radial artery, and you can see how close they are to each other. And then ultrasound guided using the equigenic needle. You follow the needle in the transverse mode. So even if I can do it like this, then you can do it also. It is really easy moving the ultrasound probe to the distal and then moving the needle, ultrasound probe needle, and you can see, you can follow the tip of the needle in the middle of the, in this case already perforating vein, and it goes straight forward to the radial artery. This is the perfect anatomy, of course. You don't see it in every case, but this is a well-chosen anatomy for the Ellipsis procedure. And then when you're at the radial artery, you puncture the radial artery, and then you can see the tip of the needle in the radial artery. You might turn around your probe if you need it to the longitudinal projection if it helps. You don't need it every time. And then when you advance the wire, you can advance the 6 French slender sheath in your proximal radial artery, and that is the most difficult part of this procedure. Sometimes it takes 7 seconds, sometimes a couple of minutes, and then you exchange the wire against O14 wire, which is required for the Ellipsis device. We heparinize our patients with 2000 units, and this is where you approach with the device. You can see the tip of the device, and then you pull back the sheath, and then you pull back the device. It hooks to the ventral wall of the radial artery, and then you close the device with a small button on the system, and then when you activate it, you see the bubbles where the anastomosis is getting created within a few seconds. To confirm the flow, you use the color flow, and then you can see that there is a flow in the perforating vein, and then it is recommended to use a usually 5 millimeter balloon to post-dilate this anastomosis to take away the waste or the spasm created by the thermal energy, and then you can see the flow, and then you have to, I do it every time, measure the flow in the brachial artery to confirm how good the flow is, and you can see in this case it's 362. So what is the evidence for Ellipsis? I've chosen the most valuable studies, the first one and also the recent ones, or people who are reporting their results. And let me break it down a little bit. The FDA trial with 107 patients met primary efficacy endpoints, and 88% of the patients had 2 needle cannulations, and the number of days was 100 days. And then recently, 105 patients, 2-year follow-up was published by Gerald Betchart in Journal of Vascular Access with almost 93% of secondary patency rates for 2 years. And those 3 centers are actually reporting, showing, or publishing their results with a lot of number of patients, 60 patients in Richmond by Jeffrey Hall with 93% maturation, 87% of 2 needle cannulations. And you can see secondary patency rates above 90%. And although he had to perform a lot of secondary procedures, this is not what we see in Europe, because we don't have to coil the branches, dilate every vein to reach that. We are using ultrasound guidance, we're using plastic needles. In Paris, Alex Malles published his initial results with 33 patients, and now he has 2 years results with more than 200 patients, 99% technical success, 96% secondary patency rates. In Hamburg, we have done 57 cases, 100% technical success, 14 minutes mean time for the whole procedure. And we have almost half of patients on dialysis, 40% catheter dependent, almost 20% had a previous ipsilateral fistula, and diabetics 37%. And we measure the flow during the procedure, 1 to 2 days after that, and 4 weeks later, and you can see this trend going up very nice. We have seen 81% of secondary patency rates, 79% maturation rates, 72% cannulations for dialysis patients, and we have looked time from creation to cannulation, 67 days min. We have done the first case of ellipsis after failed waveling more than a year ago, and a couple of months ago we have done first waveling case after a failed ellipsis. So we realized it was a radial waveling case that even when the ellipsis anastomosis occludes, it leaves every vein and artery intact, which is also a reason maybe you could start with ellipsis after all as a first choice. We have looked into the anatomical eligibility of the patients, and in Paris 63% are suitable, in Richmond 61%, in Hamburg 67% are suitable for this procedure, which is pretty good. So to conclude, ellipsis has fast procedure time, high secondary patency and maturation rates, high technical success, and fast learning curve. We don't need X-ray, no contrast agent, no coiling, no primary coiling at least. We haven't seen any steal, we haven't seen any high flow, no cannulation site aneurysm due to the shared flow probably, no ACAs. And what's important is it expands the options and it still preserves the options to create another surgical or endovascular fistula, giving our patients another functional access. Thank you very much.